Morgan. This week I am doing my presentation on pulmonary fibrosis and asbestosis. This is case study number 11. The case introduction includes the chief complaints. RI is a 69-year-old man who is referred to the pulmonary disease clinic by his nurse practitioner. He presents with the following complaints: difficulty catching his breath, and it's getting worse, a persistent dry and hacking cough, and a tight feeling in his chest. He is a retired construction contractor of 45 years. He is primarily involved in insulation installation and worked in materials in high-rise apartments and office buildings. He's been retired for about 4 years, and his respiratory symptoms began approximately 6 months ago. He thought maybe it was just his history of smoking that was causing these symptoms, so he did not seek medical attention at first. His past medical history includes an appendectomy at age 13, osteoarthritis in his left knee for about 30 years due to a football injury, cholecystectomy about 16 years ago, benign prostatic hypertension and transurethral resection about 7 years ago. He's had hypertension for about 7 years and hyperlipidemia for about 4 years and GERD for about 4 years. His family history includes his father, who had coronary artery disease, and he died at the age of 63 due to heart problems. His mother has a history of cerebrovascular disease and passed away at age 73 following several severe strokes. His brother passed away in a boating accident at 17 years old, and he does not have any other siblings. His social history includes being married and divorced twice, and then happily married a third time for 23 years, and he has 3 grown children aged 40, 45, and 49. He renovated old houses as a hobby, and he enjoys watching NASCAR racing and football on TV. He smokes a pack a day and has done that for about 45 years. He does not exercise regularly, and he drinks occasional beer with his friends on the weekends, but he does have a history of heavy alcohol abuse history in the past. He volunteers at the local food pantry for Meals on Wheels, and he does not have a history of IV drug use. He's not a very reliable historian, and he's not very good with keeping up his doctor's appointments because he says he does not like doctors. He denies a rash, nausea, vomiting, diarrhea, and constipation. He denies headache, chest pain, bleeding, dizziness, and tinnitus. He denies loss of appetite and weight loss. He reports minor visual changes, recently corrected with stronger prescription bifocal glasses. He complains of generalized joint pain and especially left knee pain due to his osteoarthritis. He has never been diagnosed with chronic obstructive pulmonary disease or any other pulmonary disorder. He denies paresthesia and muscle weakness and is negative for urinary frequency, dysuria, nocturia, hematuria, and erectile dysfunction. The patient takes acetaminophen or Tylenol, a couple tabs every 6 hours as needed, just for general aches and pains. He takes ramipril, 5 milligrams PO twice a day, atenolol, 25 milligrams PO every day, and pravastatin, 20 milligrams PO every day. And he does take Pepcid at night before bed. He has allergies to terazosin. It makes him dizzy, and he states that he's fallen twice while taking it, so he no longer takes it. And penicillin gives him a rash. Pulmonary fibrosis caused by asbestosis. Pulmonary fibrosis is a general term for the scarring of the lung tissue, which can result from various causes. Asbestosis is a specific type of pulmonary fibrosis with a known cause, the inhalation of asbestos fibers. The pathophysiology for both involves damage to the lung tissue, followed by abnormal healing processes that lead to excessive collagen deposition and scarring. The trigger can be different for different types of pulmonary fibrosis. In this patient's case, it's likely due to his background as a construction contractor and working with insulation, which includes asbestos fibers. Asbestos is a form of pneumoconiasis. Pneumoconiasis represents a change in the lungs caused by inhalation of inorganic dust particles. It often occurs after years of exposure to the offending particles with progressive fibrosis of lung tissue. In the workplace, dusts of silica and coal can be inhaled and are very common causes. And asbestos is another form of this disease process that is pretty common. Deposition of these materials in the lungs can cause chronic inflammatory with scarring of the alveolo-capillary membrane, resulting in pulmonary fibrosis and progressive pulmonary deterioration. Smoking-related emphysema and tuberculosis infection are also very serious comorbidities in many individuals. Asbestos is composed of long, thin particles which cause not only interstitial fibrotic changes, but pleural disease and cancer as well can be a result of this. This patient's history of smoking extensively for a long period of time can worsen his asbestosis for sure. Pathophysiology of asbestosis. Asbestosis is caused exclusively by the inhalation and retention of asbestos fibers in the lungs. This mechanism is centered around the physical presence and the chemical properties of these durable fibers. It leads to fiber deposition and macrophage response. So inhaled asbestos fibers become lodged in the small airways in the alveoli, or the air sacs of the lungs. Alveolar macrophages attempt to engulf and clear these fibers, but they're often unsuccessful due to their size and shape. This frustrated form of phagocytosis is a central event that can lead to inflammation and oxidative stress. The macrophages will release inflammatory mediators like cytokines and growth factors. These can include TNF-alpha, IL-beta, and TGF-beta, and reactive oxygen species, and these are released in order to break down these fibers. There's iron content on the fiber surfaces that can directly regenerate the reactive oxygen species, which can lead to oxidative injury to the local lung cells. This can cause fibroblast activation and scarring, which is inflammation or inflammatory signals, and tissue injury, which will stimulate the formation of fibroblasts to proliferate and differentiate into myofibroblasts. This can cause a deposition of excessive amounts of extracellular matrix, which is typically collagen in this case. This leads to progressive scarring. Fibrosis typically begins around the respiratory bronchioles and progresses toward more peripheral locations in the lower lobes of the lungs. Chronic inflammation and continual presence of these fibers can lead to more progressive scarring and make the lungs stiff, even after the exposure to the fibers has ceased. So this is kind of an irreversible lung damage that occurs. Hallmarks include asbestos bodies. These are asbestos fibers that are coated in iron proteins and pleural plaques that can be seen on imaging. Clinical manifestations. RI, he's pleasant but nervous. He's elderly and he appears appropriate for his stated age. He is pale but in no apparent distress. He has a very strong Italian accent and appears to be slightly overweight. His lab work is overall normal other than a slightly elevated PaCO2 level. His PFTs, or incentive spirometry tests, can reveal, they do reveal relatively healthy lung function for an elderly male. His chest x-rays show coarse linear ground glass opacities at the base of each lungs with a honeycomb appearance that obscures the cardiac borders in the diaphragm. This is something called shaggy heart syndrome, and it's a finding that's consistent with asbestosis. The CT scan revealed thickened septal lines and small rounded subpleural intralobular opacities in the lower lung zone bilaterally, which suggests fibrosis as well. Ground glass appearance involving air spaces in the upper lung zone bilaterally suggests alveolitis. Small calcified diaphragmatic pleural plaques and a mild honeycomb appearance with cystic spaces less than 1 centimeter are seen bilaterally and are also consistent with a diagnosis of asbestosis. Indicators of fibrosis or scarring indicate worsening lung function. So this can be seen by the thickened septal lines, which refers to the thickening of the tissue walls within the lung, and it's a sign of interstitial fibrosis. Small rounded subpleural intralobular opacities are characteristic early signs of scarring located just beneath the pleura or the lining of the lung. a mild honeycomb appearance. This presence of small cystic spaces or less than 1 centimeter bilaterally are a defining feature of advanced fibrosis. So this honeycombing represents irreversible structural damage to the lung tissue. Inflammation or alveolitis or ground glass appearance. This hazy appearance in the upper lung zone suggests active inflammation, alveolitis in the air spaces, which can indicate ongoing disease activity. Indicators of asbestos exposure. These are classified by calcified plaques, and they're the most common sign of asbestos exposure. They're typically benign themselves, but they can serve as a clear biomarker that the individual has inhaled asbestos and is at risk for asbestos-related diseases like asbestosis, lung cancer, or mesothelioma. The combination of the chest radiograph findings of the CT and the X-ray show shaggy heart border sign, and the specific HRCT results provide a comprehensive picture of asbestosis. The fibrosis and characteristic pleural plaques confirm the presence of asbestos-related lung disease. This imaging information, combined with the patient's clinical history, like his occupational exposure, confirms the diagnosis, even though the standard blood tests and initial spirometry were within normal limits for the most part. His low oxygenation status, subnormal chest expansion, and labored breathing with tachypnea at rest is indicative of pulmonary fibrosis due to the inability of the lungs to expand properly for optimal oxygenation. There's also the presence of inspiratory crackles at the posterior and lower lung regions bilaterally, which typically present in the lower lobes of the lungs early in the disease, and in conjunction with the CT scan results of a honeycomb appearance and ground glass opacities, it is diagnostic of pulmonary fibrosis. The role of the advanced practice nurse. Early diagnosis and treatment is pretty indicative of whether or not the patient will have a good or poor prognosis. This patient has a mixture of early signs of fibrosis and prolonged signs of fibrosis and extensive lung disease or damage. So medications that can be used for this patient include antifibrotic medications. This can be used depending on the extent of scarring. In some areas of the lungs, this may help, and then some it may not because it's a pretty irreversible manifestation. Bronchodilators and inhalers can help with opening up the lungs, allowing for more lung expansion. Corticosteroids can help reduce inflammation. Antibiotics, these patients are at increased risk for lung infections, so prophylactic antibiotics may be used in some cases, except for penicillin. We wouldn't give penicillin to this patient because he does have an allergy. Antacids, GERD is commonly associated with this disease process, so antacids may help with the symptoms of GERD. We need to avoid exposure. This patient is retired in his line of work, which was the main cause of his exposure, so that will be helpful in not having to return to work and deal with this exposure over and over again. Supplemental O2 is needed sometimes, especially if the patient's oxygen saturation is low at rest. Rehab, so lung rehabilitation, incentive spirometry use, exercising the lungs, PFTs, those will be necessary for this patient in order to maintain lung function as long as possible. Infection prevention, we talked about that with the antibiotics, just making sure you're getting vaccinated for flu, RSV, all the things that can cause major lung disorders in elderly patients, and good hand hygiene and staying away from people who are infected currently. Health lifestyle, so exercise, nutrition, hydration, these are really important to maintain optimal health in these patients. If severe and unable to, treat or adhere to medication regimen, lung transplant may sometimes be indicated, and then at the end stage of this disease, palliative care to maintain comfort will be helpful for these patients. And we have case questions. So which, if any, of the vital signs included in the case study is or are consistent with a diagnosis of asbestos? So tachypnea and low O2 saturation are conducive with fibrosis and impaired gas exchange due to inability to expand the lungs properly. What is the significance of an absence of hemorrhages and exudates on fundoscopic examination? So this doesn't have a direct correlation with pulmonary fibrosis, but with the patient's high blood pressure symptoms and decreased oxygenation status, vision impairment can be present at this time. So this looked at the retinal health and showed that there were not hemorrhages or exudates, which shows that the oxygen saturation levels have not necessarily structure or altered the structure of the retina yet, but using oxygenation therapy and improving that will help with the patient's blurry vision that he's had lately, and prevent the retinal damage. What are the symptoms, or what's the significance of the absence of JVD, hepatomegaly, and splenomegaly, extracardiac sounds, and edema? So these are symptoms of right-sided heart failure in patients with pulmonary fibrosis. This is known as cor pulmonale, and it is a severe consequence and complication of chronic lung disease. In diseases like pulmonary fibrosis or asbestosis, the destruction of lung tissue and low oxygen levels can cause the blood vessels in the lungs to constrict, which can lead to pulmonary hypertension. Over time, the right side of the heart must work a lot harder to pump blood through these restricted vessels, which can lead to right-sided heart failure. And these are my references. Thank you for listening.